And I would like to start off with Peter. The new guidelines, both 1 and 2, talk about this new terminology, art. And I've always had a little problem with art because they've unified EHIT, EFIT, EJIT together under art. But we know the natural histories could be different. And the reality is, in my mind, they should not be linked, and because the natural histories are different. But Peter, I turn the floor over to you because maybe I'm being naive.
No, this is an excellent question, and obviously the committee spent a long time whether we should give up EHIT or introduce one term of thrombus extension after endovenous ablation, and that was the goal, that there are now numerous endovenous techniques, and thrombus extension occurs above the area that's supposed to be occluded using that specific technique. And right now, EHIT, EJIT, EFIT is used, and we cannot really compare thrombus extension between techniques unless we have a basket name, and that was our goal. And we understand that, especially with glue, it can be thrombus, it can be glue, right?
Yeah.
That extends up, but I think this was still the best umbrella name that we found. Mark, you were part of this deliberation. You want to comment?
I would agree with that, Peter. And you know, number one, part of the reason for the guidelines was if you look at all of the systematic reviews, the incidence of any thrombotic complications are very low, around 1% of all of these things. And it does look like the natural history of them is pretty identical in that the risk of, and by that I mean, none of these are associated with activation of thrombin, which is fundamentally why you want to identify them, is because you activate thrombin and need to treat them with an anticoagulant. And one has to question, well, if we aren't activating thrombin, why are we treating with an anticoagulant in the first place? And none of these techniques have been shown to activate thrombin.
I beg to differ with you on foam, because they've shown between Dr. Parsi in his paper tried to differentiate between sclerosis as well as activating thrombin.
No, but if you look at all of the data, particularly from the Verathena trials, which were very well done, looking at markers of activated coagulation, it's just not there with polidocanol for it, as far as measuring it systemically.
We can agree to agree, but let's go on. So your point is, I know Jose was instrumental early on in Saphion, and the idea of, I think it was 16% that you had thrombus extension, because I think you were 3 centimeters instead of now the 5 centimeters, and within 6 months I think it all disappeared, correct? 21%. Or 21%, right? So there may be a point, but we really haven't studied it in the same manner that we've studied EHIT. But I just thank you for your explanation. I really wanted, and I will drop that question. Mark, I do have a question for you. You know, we all talk about thermal versus non-thermal and all of it, and thank you for the panel who also addressed that, Tom as well. But you know, when we look at the guidelines between the United States and Europe seem to be different, because the European Society of Vascular Surgery promoted thermal as one, to do thermal for the great saphenous vein, and then secondarily to do non-thermal. So what's your explanation with that regarding, you only quoted the U.S. literature.
Well, I think part of it is understanding how the guidelines are graded between the U.S. and Europe. In the U.S., we use the grade classification system, which requires, as Peter went over, everything be based on a meta-analysis and evidence. And things that don't have a meta-analysis to exist for them aren't graded. The European classification system allows for the introduction of expert opinion in them, which isn't permitted in the U.S. guidelines. So if you're looking purely at the evidence and the graded guidelines, I think the U.S. ones are probably stronger because there is no expert opinion involved in that. That being said, as Peter went over, there are consensus statements and things in the U.S. guidelines that are not so evidence-based, and that corresponds more to the European guidelines, which allow that to enter in. European guidelines use a very cardiology-focused system for it.
Tom, would you comment, please?
Yeah, it's even worse if you look at the German recommendations. Yeah, no, it's you hear them laughing.
Well,
but,
aren't you European?
But in the German official guidelines, high ligation and stripping is still equal to endovenous ablation, and obviously, it's truly obvious because 90% of German not private insured patients, public insured patients, are primarily treated in a short hospital stay, and the reimbursement system with the DRGs favors that so much that every doctor, every expert linked to a hospital has really a conflict of interest, and I would say not in all cases this conflict of interest is in favor of the data solved. So I think we had, if you look back at the pandemic, we had also times where expert opinions overruled data, and it's always a difficult situation when you lose the database ground. And as Mark explained that, and as I got the impression from the German system, it's not correct, but we can recognize why it is how it is.
And that's just what they are, ladies and gentlemen, guidelines. Yes, Tim.
I have a follow-up question to Mark and Thomas about stripping. There are patients, I still do occasional stripping, and I want to know your thoughts about this. There are patients who have giant great saphenous veins. It's palpable when they stand up. The saphenophemoral junction is 2.5 centimeters in diameter, and when they stand, it's a bulge at the junction. I'll just give you a scary anecdote. I told this patient that he needed to have vein surgery. He declined it for years, and then he went to some general surgeons, three of whom were all going to perform hernia surgery on him. That would have been a gnarly complication. But in that setting where you have someone who has a giant great saphenous vein, do you still see a role for high ligation and stripping?
Please.
I have to say, I do, and I don't do many, but 2 or 3 a year. And it's not so much those giant veins, but I see a lot of patients with advanced congestive heart failure who have come in after they've had 3 or 4 ablations at a facility. And when your right-sided heart pressures are that high, there is no percutaneous technique that's going to work. And those are the most common patients I see, are the patients who have right heart pressures in the 30s and 40s that just ablation is, and they prove it over and over again. And it's amazing to me that you'll see somebody they've tried to do thermal ablation in their great saphenous vein 3 times and it's failed. And to try that a 4th time just makes no sense. So I think there is a role for it still. And as I mentioned, I think those subcutaneous great saphenous veins are really easily stripped percutaneously just by putting a larger sheath in than your usual 6 French sheath. Just put a 12 French in, put a stripper up, and tie the vein to it as Jose commented, as he used to do with laser.
Tom?
Yeah, Liam, I would tell you there is no vein in the universe I cannot close down with a laser.
Jose, in that regard...
It's just a matter of energy, yeah? So The usually used 70 joules per centimeters are of course not enough to close down a 25 millimeter aneurysm. So I bring you back to the concept of endovenous fluence equivalence, where we had quite a good correlation of bigger veins with energy and their occlusion, energy doses and their occlusion. And even more, I have but only one single case, a lady, 25 millimeter aneurysm. She insisted getting the glue, and I glued her, and it worked. However, with short interval controls and additional foam treatment. So I follow her now for more than 5 years, and it's perfectly occluded. However, she has, because it's a permanent implant, the glue, she has rests of the glue in the groin, which are from outside palpable, but she's happy with it.
So, Tom, in answer to that question, I know Jose and I have always batted this one around. And Jose, what's the largest one that you've closed? And so I've done a few in the 25 millimeters, but as you can see, that I think that there's a little bit of testicular fortitude, or whatever you want to call it, in the group here. But reality is that some of us are surgeons.
We call it cojones.
Oh. In reality, you know, some of us are surgeons, and we're not so game to pick up a knife now, but, you know, there is some talk about proximal venous aneurysms and complications with that. Yeah, please, Peter.
That's exactly right, and the guidelines specifically address that if your proximal saphenous vein is greater than 3 centimeters, you should do high ligation, maybe partial excision, and if you want, distal endovascular procedure, and that's usually what can be done in most of the cases with large saphenous vein if you are really concerned, and I think you should be concerned that you can have thromboembolic complication from a large saphenofemoral junction. Then do a proximal ligation and do distal ablation.
Thank you, Tim, for that case. I'm going to go on to Paul McNeil, and we're going to talk about phlebectomy versus sclerotherapy. And now that we know that the reimbursements for phlebectomy are negligible, is your practice shifting more to sclerotherapy? Because I'm seeing more of that outside, that it's not cost effective. So what's your take on cost effectiveness, sclerotherapy versus phlebectomy?
Well, regarding the decisions I make in the office with what has to be done to a patient, I really don't think about the reimbursement, to be honest with you. But as a pattern, I'm doing more sclerotherapy now than I've ever done. I would say, again, this is just an estimate, but 20 to 30% of my patients, when I mark the veins in the procedure room, I'll say, give me some 0.3, and I'm going to just clean up the small ones that I wouldn't otherwise remove, so it's a better outcome for the patient. I was always a big component of only phlebectomy. I think that was when I was a bit younger.
Me
but
too.
now, it actually makes a lot of sense to shorten the procedure time and and treat more of the veins at the same time. So I augment with sclerotherapy. It's very effective. I don't do these mega phlebectomies that go on for 45 minutes to an hour. I don't think that's productive, even though it's out there. And it's fine if that's your practice pattern. But yes, I'm doing more sclerotherapy. You do have to sort of walk the patients through that phlebitis that they're going to get, but the outcomes are good. And I think when you supplement with the phlebectomy, the sclero and the phlebectomy are very effective.
Thank you. The other comment that I wanted to make is that I'm seeing now 2 great saphenous veins. Above knee, great saphenous, and below knee, great saphenous. And thermally being treated above knee and below knee, non-thermal. I'd like to have the panel weigh in on this one because although it may not be according to the guidelines, it's becoming almost the standard of care now as I see it. So I'd like...
Did you say baloney or baloney?
Same. Same. So, baloney. Peter.
Well, let's face it, the guideline data are mostly of treatment of the great saphenous vein above the knee or to the knee with a puncture below the knee. So it is very important whether we are talking about puncturing it mid-calf and just treating the saphenous vein to below the knee, or we are talking about a treatment of the calf vein.
So I'll give you a scenario. So you access somewhere around the knee area, and the accessor is not able to get in. And so they move proximal, or excuse me, distal, central, so that they understand that they're going to come back and they're going to touch that up with foam from below knee reflux all the way up. And I'm seeing a lot of this happening. So we used to treat the lowest point of reflux, being cautious about C2 disease, etc., but extending it more with C4, 5, and 6. And we used to do thermal down that far. Now with the advent of non-thermals, and then there's this degree of worrisome about litigation, etc. And so I'm saying that I'm seeing a lot of this, and I'm not saying it's incorrect. I'm just saying that we're being shifted to this thought based on the fact that there is non-thermal, there is no real correlation with any nerve injury. And I just wanted to take the panel's thought about it. Paul?
I just have to be convinced that there's a need to do it. Finding it is different than...
Does the patient have symptoms after you've treated the central portion of the great saphenous vein? And reality was that when we started with stripping, we went all the way down to the ankle. And then we said, well, we're going down too far and we're causing all these problems. So we went to just below the knee with a pin stripper or whatever we wanted to do. So why are we reinventing the wheel here? I think you've hit the nail on the head. It's patient should be symptomatic. So if you're treating the central portion of it and the patient doesn't have any symptoms after that, well, you can't improve that patient. Cosmetically, you might, but you're not going to do it. Anyway, thank you for that. I appreciate it. With the 10 minutes remaining, I want to pimp the panel here. So this is a 62-year-old male complaining of right leg, heaviness, achiness, swelling, throbbing, itching for several years. She's a C4A. Excuse me, he's a C4A. He has noticed some ankle discoloration, primarily following for many years, compression. Did not think it was a significant, denies trauma. Consulted Dr. Google. Patient decided that it was important to see a venous interventionalist. Father had DVT post-stripping, brother Leiden factor 5. On physical examination, brownish discoloration, medial malleolar area, pulses present, equal, varicose veins, telangiectasia at the ankle. And this is the picture. So if you look at the diagram there, you can basically see that great saphenous vein certainly was refluxing, certainly was of significant diameter, and you can see that there is a venous aneurysm just above the knee. So the question is, what would you do? Procedures? Would you prophylactically anticoagulate? Phlebectomy at the same time or stage? Compression post-procedure? How long? Well, I'm not telling you what we did, but I want to tell you that 1 week post-procedure, this is what appeared. So I'm going to start off with Tom and ask him the questions now. Would you prophylactically anticoagulate this patient based on the fact that there's a family history, etc.? And if you were going to anticoagulate this patient, how long would you anticoagulate?
Anticoagulate before surgery? Why? No, would not. Would just treat him right away.
So prophylactically, would you do it? Notice that there's a significant family history here.
So you can do that after surgery. Why up front?
Mark, how do you do your prophylaxis? If you're going to prophylaxically treat them?
You know, I probably would not prophylax. Well, that family history certainly raises some red flags, but it was a post-operative, post-stripping DVT, which in most of the literature doesn't carry substantial risk for recurrence, so I think that makes
Family member had Leiden factor V.
that really, the family history is more important than the factor V Leiden. So factor V Leiden is about the same risk as non-type O blood, which a lot of people in this room have. So I would not, I wouldn't, based on that, I would pay attention to family history of DVT, which is more important than the factor V Leiden, but given that it was a post-operative DVT, I probably wouldn't.
So if dad had factor V and brother has factor V, and let's say this patient's a known factor V, would you prophylax this patient? Heterozygous. Would you anticoagulate?
I would not.
Okay.
And
Would
I have a pretty low
anybody on a
threshold.
panel disagree?
I would give, intraoperatively one dose.
And do we know that one dose works?
We don't, but we don't know what, more. There is no real significant difference between a single dose or 1 week of low molecular weight heparin.
Well, we do know that and Caprini always talks about the orthopedic study and the plastic surgery study, that one dose doesn't matter. You got to either do 7 to 10 days or 30 days. Now, with that being said, there is a new study that's going out in Europe looking at exactly that in terms of anticoagulation. I think it's called the Thrive study, but yes. Tim.
When you showed that image of what I think is the great saphenous vein longitudinally, preoperatively, and you saw that there was some echogenic thrombus.
That was post.
That was post?
Yes.
Oh, sorry.
Sorry.
But I thought it was a pre-op picture, and if there was a little bit of thrombus that is incidentally seen in the great saphenous vein, which you see on an ultrasound periodically, if it's just a very focal echogenic thrombus, I don't anticoagulate those patients. The original trials that led to the approval or recommendation for anticoagulation for patients with superficial vein thrombosis were inclusion criteria were 5 centimeters of superficial vein thrombus, and that just looked like a little ditzel.
Ditzel?
Like gnarly.
Okay.
If I was concerned about a post-procedure DVT in a patient like this, which I'm really not, I wouldn't pay any attention to that dilated greater saphenous. I would just treat that I would ablate it and I wouldn't think about it again. But if I was concerned about anything, it would be the varicosities, and I would combine an ablation and a phlebectomy at the same sitting just to eliminate everything. That's how I would approach any perception of an increased risk of DVT. But I wouldn't anticoagulate.
Julian?
Yeah, I would take into account a lot of factors here, whether the patient is obese, or how far they live, or they're driving a lot of hours. But if you look at the risk of, the concern here is what's the risk of DVT and what's the risk of bleeding complication from the oral anticoagulation. The risk of bleeding complication from OAC is about 1 to 2% per year. So if you give him 7 days of treatment, the risk of her having bleeding complication for 7 days is very, very little. From the other perspectives of legal or anything, she happens to go and develop a DVT, I would prefer to treat them for 7 days with oral ASC. The risk of her having any bleeding issue for that short amount of time would be very little. And but I would take into consideration other things. Is she driving 2 hours? How active is she? What's her weight? And other things that could play a role in it.
So the interesting thing in the UK, they do prophylax the majority of their patients, but they don't get ultrasounds post-op. We don't anticoagulate, and we get post-op ultrasounds. But as Paul alluded to, you know, if you look at this little ditzel, as he calls it, even post-procedure, doesn't really matter. And I would tell you that the guidelines right now suggest that you don't get an ultrasound post-procedure. You would never have picked that up. Historically, 14 to 21 days, these are going to go. And even if it did embolize, how much do our colleagues who do access clearance for dialysis, how much clot do they move north? So I am one that agrees that no anticoagulation is necessary. I would not have even gotten this ultrasound. Unfortunately, this was before I really knew the historical idea. But I want to go back to one thing, and that is there. If you look at this venous aneurysm, I actually did thermal ablation on this patient. And what do you think happened in that one area? It was all in the fascia. It was right underneath the skin. Palpable. And what did I learn, Mark?
You probably got a big lump there that hurt for a little bit, and you complained of for the next 3 months.
Exactly, 100%. So yes, patient had a lump. It was even a little bit red and gnarly. No, oy vey for me. But anyway, what I learned from that is that if you have something like that, you should really remove that segment, phlebectomize. Now, we looked at the question of doing phlebectomy at the same time or difference, and we know what the literature says, but I want to know from the audience, who would do phlebectomy at the same time they would do ablation on this particular case? And who would stage? And how many don't know? Because there are only like 10 people raising their hand. So I couldn't get a good adequate poll.
That's two different questions, though. What would you do? And do you know that's the right thing to do?
Ask the question. Say again.
Well, there's a difference between what would you do and do you know that's the right thing to do? Because I think it's the right thing to do, and I think it's sort of supported by the literature, but it's not real strong.
So I think one of the things, and you'll have the last word, but I think if you're doing a non-thermal, phlebectomy at the same time really kind of doesn't make a lot of sense to me. But if you're doing thermal, 100% for me. Tom.
Again, you brought into the game to phlebectomize the aneurysmatic GSV?
That area, yes.
I would never do that in a fascia. So why not just turn up the laser a little bit more?
We did. We closed it. It was not a question. It was the post-operative
you
problem.
need to see the shrinkage of the vein in the ultrasound picture. And if this is not enough, you go back and treat it again.
You know, I always, when I come to that segment, I actually increase my joules per centimeter because you've taught me that a long time ago.
And there should
But
be
it
no
didn't
aneurysm
work.
at the end.
Fair enough. Any last comments?